Okay. Hello. Happy Halloween. This is not a trick. It's a treat today. My name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. We are very excited to be bringing you the launch of all new CHIS 2016 data, as well as some cutting-edge research on a very vulnerable group. So thank you for attending, and thank you to our online folks as well. However, before we begin, let me just put in my promo for next month. Next month's seminar is going to be on November 30th. It is about nutrition programs to combat obesity and diabetes and other health effects in South LA. Because in Central and South Los Angeles, 30% of adults are obese and 36.5% are overweight. In this November 30th seminar, Susan Babby, co-director of the Center's Chronic Disease Program, and Zhao Chen, who is our Associate Director of the Center's Health Economics and Evaluation Research Program, will discuss their evaluation of various obesity prevention programs implemented by the LA County Department of Public Health. And those programs include farmers markets, community gardens, healthy eating and exercise classes, as well as stricter standards for healthy food programs. So please join us again. That's November 30th at noon. As for today, we will be recording the seminar, and it will be placed on our website at the address you see at the top of the slide. If you would like copies of today's slides, please email me, gdriscoll@ucla.edu. And we will also have a brief question and answer period at the end of today's seminar that I will moderate. And if you want to get news of our upcoming seminars, events, new research and data, please subscribe to our popular e-newsletter, Health Policy News. That's the link you see at the bottom of this slide. Okay. The California Health Interview Survey is the nation's largest state health survey and California's official source of health information. So that means a new batch of CHIS data is always very exciting news. The data we are releasing today were collected in 2016, a somewhat nostalgic time in terms of national healthcare debates. As you will see, enrollment in healthcare reform coverage programs was at an all-time high, and there are many other fascinating indicators on hundreds of topics, from dental care to diabetes to marriage and to even to housing. CHIS Principal Investigator Ninez Ponce and CHIS Director Todd Hughes are here to give us the highlights. In addition, and because of California's diversity, CHIS is also known as a unique source of information on many vulnerable and undersurveyed racial, ethnic, and sexual minority groups. Since our inception, CHIS has surveyed gays, lesbians, and bisexuals, but starting in 2015, CHIS started surveying transgender people for the first time. And we did so thanks to a truly cutting-edge two-step question methodology that's going to be explained by our speakers, devised in partnership with the Williams Institute at the UCLA School of Law. With the release of this 2016 data, we now have enough sample to report some of the first population-based findings on this very underrepresented group. With us today to brief us on these findings are the Williams Institute's Jody Herman, who is a scholar of public policy, and Bianca D.M. Wilson, who is the Rabbi Barbara Zaki Senior Scholar of Public Policy at Williams. Thank you very much for coming, and please welcome our speakers.
Thanks, Glenn. Hello, everybody in the audience and out there in this webinar. I'm Inez Ponce. Improving the health of Californians, a group that is diverse by geography, by race, language, income, sexual orientation, requires a population survey, and a large one at that, one that can provide comprehensive information on a range of health topics, health status, health conditions, mental health, oral health, health behaviors, access and use of health care, health insurance, employment, where you work, what you do, and several other characteristics. I'm very happy today to announce the launch of the California Health Interview Survey, or what we fondly call as CHIS. This 2016 data, I'm nostalgic because I was around in the 2001 first ever launch. So this is 15 years or so since the launch, where we've been collecting data on the health of Californians. And since 2001, we've always aspired to push the frontiers of being a leading population health survey. We were the first in the field to better represent the needs of the California's population on several aspects. Not only do we provide decisions, big decisions on healthcare reform, but also important insights on health status and health access among groups where data has been historically hard to come by, or they've been lumped together in a larger aggregate category to hide risks within this group. So some notable examples are, we've been collecting data on American Indian Alaska Native tribes, state and federally recognized affiliations since 2001. Several years we've been collecting on Asian ethnic groups, as well as collecting in language in several Asian languages. And we've been collecting on sexual orientation since the inception of CHIS in 2001. So with this long-standing data frontier spirit, I'm very pleased to feature in our webinar today our gender identity results that will be presented with our colleagues from the Williams Institute here at UCLA Law School. But first, let me hand the presentation over to the CHIS director, Mr. Todd Hughes, who will describe the purpose of CHIS and how it is done.
Thank you, Ninaz. So the California Health Interview Survey, or the CHIS, was created to inform state and even national policymakers on key health topics. Given the current debate over healthcare reform, it's more essential than ever that the CHIS produce timely, objective, evidence-based information for lawmakers, advocates, researchers, and the media. Thanks to the ongoing collaborative funding and support that we receive from the federal and state government, from other sources as well as private foundations in California and elsewhere, we're able to help fulfill this mission and key purpose. One of the key design features of the CHIS is the information that it provides below the state level. It's high-quality state-level data that is a feature of the California Health Interview Survey, but our sub-state data is critical to our mission. We provide estimates for most individual counties in the state while grouping together some counties with small populations, and even provide sub-county estimates for service planning areas in Los Angeles County and health districts in San Diego County. Going beyond these small geographies, the CHIS is also designed to provide information for all of California's major race and ethnic groups, as well as some other smaller population groups, such as the state's transgender population that we'll be highlighting in today's seminar. Additionally, it has been a foundational principle of the CHIS mission that the important information that the survey provides should be freely available to wide audiences to enable as many users as possible to make data-driven decisions for California. The CHIS is a household survey of California residents which conducts telephone interviews with one adult in each selected household. It also collects information for one adolescent and one child if they are present. In order to reflect the linguistic diversity of California's residents and to ensure that we collect data from as many sample households as possible, the CHIS is conducted in English, Spanish, Chinese, including both Cantonese and Mandarin dialects, Korean, Vietnamese, and Tagalog. Copies of the questionnaires are provided on the CHIS website, and translated versions are available at the link on this slide. In 2016, the CHIS completed over 21,000 interviews with adults, over 800 interviews with teens aged 12 to 17, and over 2,100 interviews for children aged 0 to 11, conducted with a knowledgeable parent. Because it reflects California's diversity, CHIS is relied upon for its wealth of data on many racial, ethnic, and gender minority groups, and counts of interviews in 2016 by each racial and ethnic group are displayed here on this slide. In order to accomplish these objectives, the CHIS relies upon many different sampling strategies to ensure that we can effectively represent each of these varied groups to the extent possible. As I mentioned earlier, one of the key strengths of the CHIS is the diversity of topics that we include in the survey in combination with our mission to measure these characteristics for small population groups. In connection with this mission, it has been our privilege to collaborate with our colleagues at the Williams Institute at the UCLA School of Law for the past several years to develop, test, fund and implement key questions regarding gender identity in the CHIS starting in 2015. And so it's our pleasure today to be able to share with you findings from the 2015 and 16 CHIS on characteristics of transgender adults in California. And I'm very happy to introduce to you our next speakers, Dr. Jody Herman and Dr. Bianca Wilson.
Good afternoon. Okay, so we're really excited to be here to join you to review the key findings from the Adults in California brief, which we co-authored with our colleague Tara Becker here at CHIS. Yeah, so we're happy to join you. We're really here on behalf of a collective of folks at the Williams Institute that have worked with the collective here at CHIS, and as both Inez and Todd noted, this policy brief is really the culmination of several years of testing and implementing new gender identity questions to CHIS. As you know, gender, of course, was measured before, but previously not in a way that we could assess the transgender population, rendering them invisible. So we engaged in a collaborative project between the two centers here on campus, in which we identified a range of ways that transgender status could be measured. Let me see, is it to the next one? Okay. Ways that transgender status can be measured, and using experimental design to determine which approach worked best. So in the end, the following two-step measure performed best and was ultimately used in the 2015-2016 cycle, where you see that first respondents are asked about their sex assigned at birth, and then asked about their current gender identity with the options of male, female, or transgender. Using this type of measure, respondents are identified or categorized as transgender if their sex assigned at birth is not the same as their current gender identity, whether that's choosing male or female or transgender. And when we use the term cisgender, that refers to those respondents whose sex assigned at birth is the same as their current gender identity. I'll turn it over to Jody Herman to talk about the findings.
Thanks. Good afternoon. So in the report released today, which is available both on our website and I believe the CHIS website as well, we described the findings regarding demographics, health, and healthcare access for transgender adults based on the two-step measure that Bianca described. The report provides much more detail, but today we'll just briefly highlight the findings regarding health disparities between transgender and cisgender adults in California. But first, we wanted to look at some of the demographic findings for transgender adults. So based on the two-step measure that Bianca described, we obtained an estimate that about 0.35% of California adults are transgender, and this means that their gender identity differs from their sex assigned at birth. This translates to approximately 92,000 transgender adults in California. This estimate is similar to population estimates that were obtained in other studies, especially when you look at the 95% confidence interval, which is there on the slide. It ranges from 0.15% to 0.55%, and other studies ranges have overlapped with that. So pretty similar to other results. So in regard to other major demographics, we see that 64% of transgender adults reported their race and ethnicity as non-Hispanic white. And this is a significantly higher proportion of non-Hispanic white adults than we find among cisgender adults, of whom 39% are non-Hispanic white in California. So our trans population is more likely to be white and less likely to be Hispanic. So when asked about how they currently describe themselves as the current gender identity measure, nearly half of the transgender respondents currently describe themselves as transgender, whereas 32% reported female, 7% reported male, and 15% reported a gender not listed. Transgender adults were significantly more likely to report being gay or lesbian or bisexual at 65%, compared to cisgender adults, only 5% of cisgender adults identify in this way. In regard to education, 38% of transgender adults had a bachelor's degree or higher, and that's the exact same percentage that we found for cisgender adults. 32% of trans adults were living at or below 138% of the federal poverty line. So this was slightly higher, but not significantly different from cisgender adults at 28%. So in regard to these demographics and other demographic findings in the report, we just found some similarities and also some differences between trans and cis adults in California. But we also find in regard to health and healthcare access that also this mix of similarities and differences. Let's see. There we go. So we looked at multiple areas of health and healthcare access available in the CHIS to determine whether transgender and cisgender Californians were faring differently in these areas. On most of the outcomes that we looked at, transgender and cisgender adults were not significantly different. Yet there were several areas where differences did emerge. And for example, in the area of mental and physical health, this chart illustrates some of those differences. For instance, in lifetime suicidal thoughts and suicide attempts, transgender adults had a significantly higher prevalence than cisgender adults. 34% of trans adults reported having ever had suicidal thoughts, compared to 10% of cisgender adults. 22% of trans adults reported having ever attempted suicide, and that compares to 4% of cisgender adults. Trans adults were also more likely to have experienced serious psychological distress both in the past year and in the past 30 days. 33% of trans adults experienced serious psychological distress in the past year and 15% in the past 30 days. And those were significantly higher than their cisgender counterparts. 60% of trans adults reported having a disability due to a physical, mental, or emotional condition, and that's significantly higher than cisgender adults at 27%. You'll also find in the report that transgender adults who have had more than one sex partner in the past year were significantly more likely to be living with HIV than their cisgender peers, and that was 35% compared to 2%, so a very large difference. Trans adults were also significantly more likely to have emotions that interfered with some aspect of their life, including relationships, social life, ability to do chores, and work performance. And finally, trans adults were more likely to delay or not get medicine that a doctor had prescribed to them. So there was a delay in getting that type of medication, prescription medication. So again, the report contains all the detailed findings for these and other measures, so we encourage you to look at it. And at this point, I'll turn it back to Bianca to tell us what's next.
Sure. Yeah, I just want to say a little bit about, let's see, just going forward, there we go. These key findings, they point to several areas of needed interventions as well as future research. First, where we see differences between cisgender and transgender people in California with regard to mental health disparities, we just want to point out that these seem to really reflect patterns of differences that we see across a number of studies using different methodologies, different types of sampling techniques. So there, we see some replication and those differences were expected. Now, in a few areas where we might have expected to see differences, such as indicators of poverty or economic instability, and we did not see differences, there's more, we're looking forward to understanding more about why that is. It's quite possible that it reflects an actual, what we would expect in the population, that there are in fact more similar, and maybe this is a function of what it means to be in California with highly protective public policies for sexual and gender minority people. It's also possible that, this is the first couple of rounds of data collection and it's a small sample size. Excuse me. So moving ahead, we'll be looking at how additional years of data will provide more precise estimates and really strengthen the analyses, and that'll be really important to look at. And then, finally, which is why next steps, regardless of kind of additional analyses, the clear findings demonstrating mental health disparities, and particularly with regard to suicidality, definitely point to the need to invest resources in not only future research to understand the factors associated with those disparities, but also interventions that help to decrease those rates. So thank you.
Oh, excuse me, before we get going, Bianca, we just had an online question.
Yes.
Because we're having some sound issues.
Oh,
You
yeah.
could repeat the finding on HIV status.
Oh, yes, correct. Jordan.
Oh, sure. So it's limited. Yeah, no, it's not on there. It was just something that I mentioned. So it was out of those who had had more than one sex partner in the past year. Trans adults compared to cis adults out of that group had a much higher prevalence of HIV than cis adults. And so that was 35% compared to 2% out of that group for people living with HIV.
Thank you. I'm back. Thanks, Bianca. Thanks, Jody. Again, a plug for their policy brief. It's produced both at the Center for Health Policy Research, you see this, and as well as the Williams Institute. And there were a number of indicators that were not presented today. Again, like not only just HIV status, but prediabetes, diabetes, asthma, for example. And again, we thank you for this collaboration. So CHIS data can also provide insight on health insurance status in California, specifically since we've been collecting data since 2001 and on an annual basis since 2011, that we can provide insights on the pre-ACA period compared to the post-ACA period. There are two notable products from CHIS. One of them we released today. Tara Beckler is also the co-author on this one. Thank you, Tara. On the number of uninsured in California. It's going down as expected. We are at a record low in 2016. And that fact sheet, again, is here. So it's so fact sheet is shorter than a policy brief, but it's very visual, quick estimates and insights on key topics in California. And so we have this on the number of uninsured in California. We also are sponsored and work with the California Healthcare Foundation on providing data to their fabulous tool, the ACA 411, which has data not just on CHIS, but several other sources. And this lookup source can provide insurance coverage, access, and healthcare services, and monitoring the progress of the ACA. Many more publications can be found at healthpolicy.ucla.edu. So this chart is from the fact sheet on the number of uninsured, and the uninsured, let's use the mouse, it's this gray line here that's a diamond. So we have from 2011, 12, 13, pre-ACA period. 2014 was the beginning of the Medicaid expansion and covered California. So we start to see a decline in the uninsured rates beginning in 2014, a dramatic decline in 2015, as we reported last year in this webinar, and continuing decline, but starting to slow down, stabilizing in 2016. So 2016, we're at 8.5% uninsured rate for the population in California under 65 years old, so those who typically are not on Medicare. And we continue to see that the driving force of this decline in uninsurance rates is through the expansion of Medicaid, the increased enrollment of Medicaid. In 2016, about a third of the non-elderly population in California are supported by California's Medi-Cal program. And that amounts to an estimate of about 11 million. The 8.5 million remaining uninsured is about 2.8 million. And so let's take a look at among these uninsured, we ask questions on what's the reason why they continue to be uninsured. And again, for this population group, age 0 to 64, looking at different income groups as expressed by the federal poverty level, we see that the reason that they can't afford it has gone down since 2013. And this reason has gone down for all income categories, but significantly among the lowest income groups. So notably the 0 to 138% poverty level, which is the qualifying level of income for the Medi-Cal population, and the 139 to the 400% federal poverty level, the qualifying income to qualify for subsidies under the Covered California program. So 2 expansions under the ACA. Apart from affordability, one of the provisions of the ACA was that, how many here have had a routine exam? Okay. Do you remember in 2014 that when you went, and if you're insured, that you didn't get charged a copay, right? So one of the provisions is to incentivize the population to go see their doctor in the annual routine exam, and doing it by removing the patient co-share. And with that, so we see from 2013 compared to 2016, we see about a 4.5% drop, increase, not drop, an increase of adults receiving routine checkup in the past year. This 4.5% drop in a population of about 32 million people translates to over 1.5 million who have increased, who have gone to see their doctor for routine checkup. Why is that a good thing? Well, it's a good thing because your doctor then can detect at an earlier stage, possible pre-diabetes or borderline diabetes. And in fact, in this screenshot, so we opted to show the CHIS. It's a little hard to see because we wanted to show that this was generated from the free web query lookup called CHIS that also went live today. Went live with not just on pre-diabetes borderline, but also on over 200 indicators. So what this shows is that since 2013, which is at this rate here, it's about 10%, that we've seen an increase in pre-diabetes and borderline diabetes. Last year, our team here, when we first saw this, thought that there was something wrong statistically. Well, all of a sudden it jumped, and how could that be? All of a sudden, our population is pre-diabetic. Maybe because we didn't do the soda tax completely then. But it appears that now with 2016, it's about the same, so it stabilizes. So fundamentally, I don't think there's an epidemiological shift that occurred here, disease shift, but that there was a detection shift. So a shift where going, all those over 1.5 million people that now go see their doctor for a routine checkup now have the opportunity to be forewarned that there should be lifestyle changes or perhaps early treatment that can abate or possibly just avert diabetes, and which is fabulous for individual well-being as well as for the costs in the health system. So now I'm going to turn to Todd on what's new.
Thank you, Ninez. So as Ninez mentioned, there are over 200 different indicators currently available from the 2016 survey on our online dissemination platform, CHIS. What will you see that's new and different? Well, this year, in 2016, there were a set of questions, thanks to the support of the California Wellness Foundation, a set of questions about dental and oral health. And those include questions about the reason for your last dental visit, overall assessment of your condition of your teeth, when the most recent dental visit occurred, and status for dental insurance. So these are new topics that were added in 16 that you can now find available on CHIS. Additionally, most of the content in the CHIS remains stable for a 2-year cycle. So last year in our data release, we conveyed information about a number of new topics that were added in 2015. However, most of that stays stable through the 2015-16 cycle. These are the new topics that were added. But there is a document available online at this link, which describes what's new and notable in the CHIS for the full 2-year cycle that I encourage you to go online and read. Many of the enhancements to the methodology that were included in 2015 have been carried over into 2016. This includes things like expanding the percentage of our sample each year that's interviewed from a cell phone frame instead of just a landline frame, rising up to 50-50% split versus 80-20 favoring landline in the past. So this and many other enhancements for the whole cycle, as well as the specific changes for 16, are available in this detailed sheet at the website here. Next, we'd like to shift gears and talk a little bit, for those of you who are less familiar with the CHIS data, about how you can access the CHIS data and how that can help you meet your policy and research needs. So as we have our objectives for disseminating data, there are a few guiding principles that are key for us. First and foremost is to protect and preserve respondent confidentiality. We have a lot of powerful tools out there, but we must be sure that we are always protecting respondent confidentiality so that we can continue to encourage respondents to participate in the survey going forward. Second is to democratize our access to the data, to make sure that the data are available to as many users as possible and can be applied to as many different situations and policy needs as possible. Third is to reach a large and diverse audience across different divides of technology, skills, and resources. Not everyone has a degree in statistics, but that shouldn't prevent you from understanding the CHIS data and using them to your needs. And so we have a set of tools that we employ that allows the broad set of users to do this. And there are different tools for different users with different needs. First, the top of this graphic describes what might be more appropriate for the power users and the really technical needs for accessing CHIS data. Whereas lower on the list, you start to get into more user-friendly and accessible tools for a broader audience. And on the side, we have a green bar here that represents our health data program, which is data advocacy, training, and assistance, which helps to build capacity through training sessions to help you understand CHIS data. And I've got some exciting information about new tools related to that in a moment. But first, the Data Access Center is available to researchers who would like to request custom tabulations and to really dive into specific data needs. It allows those researchers to collaborate with researchers here, where our researchers can run programs on the data here and provide outputs to those researchers to meet those needs. If you don't need that much assistance, but you'd like to have access to the set of data, the public use file allows you to have broad access to a number of the indicators and data points and records within the CHIS in a very protected way that preserves confidentiality. And that's available for free for download. The 2016 PUF, as we call it, was released this morning, and so it's currently available for you to download in SAS, SPSS, STATA format, multiple formats available. The three lower topics here on the screen, these tools are designed for somewhat less power users and are more broadly accessible, including the Ask CHIS online data query tool, which Nina showed a screenshot of. A very powerful tool to take any of those 200 indicators, cross them by many other indicators, examine trends across geographies, examine trends across time. It's a wealth of data, and I encourage you to dive in for our 2016 data that's there. Ask CHIS Neighborhood Edition provides more detailed small area estimates down to lower levels of geography, which I'll discuss in a moment. And health profiles are PDF format or online summary statistics for a wide set of different groups and geographies. So this slide demonstrates the difference between the different online dissemination platforms in the geographic detail that they provide. So the Ask CHIS system, which was updated and released today for 2016 data, can provide estimates for the state level as well as for counties. And that includes sub-county areas for the counties I referred to earlier, Los Angeles County and San Diego County. However, to get below that, we understand that many policy and implementation efforts really require smaller geographic data. And so we have developed the Ask CHIS Neighborhood Edition tool, which uses model-based estimation to produce estimates for Assembly, Senate, and congressional districts for the state of California and for the federal districts within the state, as well as cities and down to the very small levels of geography for us, which is the zip code level. Ask CHIS Neighborhood Edition has not yet been updated for 2016 CHIS, but will be later next year. One exciting new enhancement that we've been able to provide this year is an online, on-demand learning center. So if these tools are a little too intimidating for you and you don't feel prepared to use them yet, we encourage you to access these free online tutorials to be able to understand how to use the data. It's available at the healthpolicy.ucla.edu website, and they contain a number of different topics. They're intended to be easily digestible, about 10 minutes each, and they're designed for a wide set of experience, even if you have no experience accessing our online data tools. And because they're pre-recorded and available online, you can access them anytime, anywhere. They cover things like how to run basic queries and display data visually or export them into other formats, as well as some basic statistical principles about confidence intervals, pooling, stability, and much more. In a broad sense, the CHIS.ucla.edu website has a number of important resources and tools that we encourage you to visit to better understand the CHIS data and their value. And we would like to take this opportunity to thank our UCLA Center for Health Policy Research CHIS team, whose names are listed on this slide, whose tireless efforts over the last 10 months have allowed us to be able to take the 2016 data and package it and produce it in this release today. And we thank the team for their efforts. And at this point, I'll invite the full set of panelists to come back up, and Ninez and our colleagues from the Williams Institute to be prepared for questions.
I just wanted to do a shout out to Peggy Toy, who heads our health data project, who helped with, you can't really see her, but she's in orange over there, who helped with the production of the on-demand tutorials, as well as continues with, I said about, CHIS having a long-standing data frontier spirit. We also have a long-standing data democratization, tradition, and that we are also available to provide training, workshops and training for your community groups. So I wanted to thank you and your team.
Okay, sorry. I'm doing social media.
We don't know how to tweet and talk yet. So.
Okay.
Okay, so we're going to do Q&A now, and I have a bunch of questions already for the Williams folks. But how I like to do this is I like to take one from online, one from the room, and back and forth in order to be fair. So, Williams folks, a couple of questions for you. They wanted to know if substance use data was analyzed or could be analyzed with the CHIS, and also could we talk in general, folks, about plans to release data on transgender children and youth under 18?
Great question. So for the current study, we did not look at substance use. It was not available yet in terms of numbers. So here it was a sample size issue, but we agree it's an important issue and something that we'll be able to hopefully look at after the next cycle or two. With regard to trans children, and that's something that we would hope to be releasing in the next month or two. Not transgender children, as we didn't measure gender identity in the adolescent survey, but what we did look at is gender expression, which is also a very important, is not only connected to gender minority status with regard to trans children, but by itself is an important factor associated with mental health disparities and experiences of bullying. So we did measure gender expression and hope to be releasing that report in the next month or two, looking at gender nonconforming youth compared to gender conforming youth.
Okay. Anybody in the room? Questions in the room? All right, I'm gonna keep going then. Okay, next.
Okay, next question. Why only ask these questions of adults up to the age of 70?
That actually might be
Be
better
a
addressed
CHIS
by the
question,
CHIS team.
right?
You can take that one if they want.
We hope to have more funding
Yes.
to collect data over age 70, but we are aware that that was a cutoff based on resources.
Yeah.
Right. Exactly. In the room, we're talking about if there's a funder,
listening, please fund us. Okay. Does CHIS in general ask about HIV status? Was the question.
Yes, CHIS has questions about HIV status and several questions about whether or not people get tested, and then whether or not their self-report and whether or not they test positive. So those are the items that we use specifically for the transgender compared to cisgender analyses, but CHIS has those data available for Californians generally. Todd can speak.
Let me just add to that as a preview of things to come, in the 2017 CHIS questionnaire, there are additional questions where we ask about screening for HIV as well as for pre-exposure prophylaxis, PrEP, Truvada, et cetera. So there'll be additional data enhancing the value of what we collect already in the 2017 CHIS data.
From Office of AIDS.
Oh, excellent.
Anybody have any question in the room? Gwen.
Yeah.
So you mentioned that the transgender population.
It's like technology wanted to be the trick today. For
There's a
Halloween.
ghost in the
It's participating.
I think gremlins too.
Gremlins, yeah.
Yeah. So you mentioned that the transgender population are more likely to delay in care, but when I look at the insurance status, they actually are covered. So what do you foresee the perceived barriers in access?
That's a great observation.
Okay, well, the significant difference that we found was in access to prescription medications. So once you are prescribed a medication, your ability to actually go and then get it. And for some reason, the trans population is not getting the medications. They're delaying or not getting the medications that are being prescribed to them from a doctor. And so we don't necessarily know why that is, but it requires further investigation. But yeah, in terms of insurance coverage, we found that they were pretty similar to cisgender adults.
And I think you're picking up on a really important point that, subsequent years of data can help us think about. Is there something about this protective environment of California that might help, say, decrease certain types of disparities, like economic insecurities, potentially, at least among some subgroups of trans folks, access to health insurance, and yet still we would see some other disparities that might be more directly associated with, for example, anti-transgender bias, which has been documented in other studies looking at the experiences of gender minorities in the healthcare system. So, it's an important thing to think about. Well, in this case, maybe it's not about whether or not they're covered or insured, but rather, is there something else going on in the interpersonal experience of accessing healthcare, which we, again, we're not able to speak to with these data yet, but that's something for us to think about what else is going on.
So we do have, it probably wasn't enough sample, but we do have questions in CHIS on reasons why you delayed or forwent for care. And we also have in 2015-16 questions on discrimination in receiving healthcare. So that may be something we could look at.
Yeah, and I think for this round it was just a sample size issue.
Yeah.
But, we could keep looking at that.
Okay. Do we have any data suggestions on improving access to mental health services for transgender Californians?
Say it again?
Policy recommendations, or what is the recommendation for?
Yeah, I think, the fact that the data, so we keep saying small sample size for some of the indicators where we'd expect differences. The fact that despite those small sample size, some of those mental health disparities still emerge, I think speaks to the degree of concern that we should have in terms of this very marginalized population. And they clearly indicate that, in addition to our positive public policies that we have that are intended to protect against discrimination, that we need to be looking at how well those policies being implemented, evaluating them, and are we really creating that pathway between protective policies and really ensuring the well-being of transgender adults in California? So I think it highlights a need for an increase of services and an understanding of how all the policies are being implemented.
I would also add potentially, investigating, looking at training for mental health professionals and cultural competency would be a next step as well.
Yeah, good point.
So this is a CHIS question. If people want to analyze this data themselves, is the transsexual question on either Ask CHIS or in the PUF? And then if not, how would people who want to do analysis access the data?
Why don't you go ahead? You be the bearer of this.
Yeah, I get stuck with the mic on the bad answers, but no. Well, as I said earlier, it is one of our key priorities: protect confidentiality in the ways that we disseminate data, and this is one of many other items on the CHIS questionnaire that are deemed to be quite sensitive and create a risk of exposure if we were to include them in the public use files, and so we do not provide access to them in the public use files. However, if researchers do have an interest in running some analyses of these data, they can collaborate with us through the Data Access Center, and we can examine each proposal based on its merits and make a determination about whether we can proceed with that.
So it's not an Ask CHIS?
It is an Ask CHIS, but to be able to dive down into some of the more detailed analyses, there's basic information provided on the Ask CHIS platform.
Yeah, for example, HIV status is not available for public use.
Right, and the Ask CHIS system has built into it certain filters and advisories about the reliability of the data. So when you start to cross any variables by each other, when sample sizes are small, either cells will be suppressed or you'll receive an indication that the data are unstable.
But, sorry, I want to underscore that the Data Access Center is open to everybody. You do not necessarily have to collaborate with one of us or with Bianca or Jody, although it would be fabulous to collaborate with them. But you can have your own investigator-initiated question and apply for data access in the Data Access Center.
This is a journalist asking, so she's a friend of mine, so I'm just gonna.
Okay, could Jody or Bianca comment a little bit more on the significance of the mental health disparities between transgender and cisgender populations and what policies could help mitigate those disparities?
Well, I think what I'd reiterate is that at this point, at least in California now, that assumes, well, I'll get to that. So here in California, we have a number of policies that are intended to protect all of us against discrimination, and those policies currently enumerate or name gender identity, at least here in California. So that's a great start. One, we also know that just because we're in California, we're not just exposed to what happens in California. So we're also impacted by national policy and national public policy debates. So with that said, I think we need to both look at how well the policies here in California are being implemented and evaluated. I don't have any recommendations for additional public policies that are needed. I think if we think of the rates of suicide among transgender adults as likely being associated with experiences of discrimination and bias targeting trans folks, our current California policies seem to get at most of those issues. So then it's how do we get the implementation of the policies to trickle down to community effect? But then to also recognize that we live in a complex society where there are also national debates and national policies that impact individual trans folks regardless of where they live in the country. And, you know, there on the national front, we still have a lot of work to do. I don't know if you want to add to that.
Well, I would also, well, it's a reiteration, I guess, where, you know, there are great policies around access to transition-related healthcare also within the state of California, but we need to make sure that that statutory level of access is actually making its way into people actually accessing the care who need it. So, you know, there are studies that have looked at the relationship between access to gender-affirming care and suicidal thoughts and behaviors, and there's a, you know, significant correlation there. So we need to make sure that not only do we try to address the, you know, stigma and discrimination that people are experiencing that adds to minority stress, but also getting good access to gender-affirming care for those who need it, and you know, also access to care generally, like we were talking about with mental health services. So.
Any questions in the room?
Okay. I want to assure folks online, if I don't get to your question, you can email me and I will get your question answered. And the same goes for folks in this room. Again, that's gdriscoll@ucla.edu. But because of time, I want to get us out of here promptly. I'm going to give the CHIS team a really good one to answer, to send us out. And that is, how well would this, how well would this survey stand as a model for the majority of people in the U.S.?
Well, I think, so the question was how well would this survey stand as a model to depict, represent the majority of the people in the U.S.? Well, we're a representative survey, so we don't just care about the majority. But that said, California, in many ways, has, like, I see, like, there's like 5 Californias. There's different microcosms that could represent the Midwest, that could represent the South, that could represent the Northeast. And so I think because California is a large state, and there are differences, microclimates, both you know, by weather and by politics and by economics, that we're able to provide a swath of information of a large sample, 20,000 each year, of a large state, you know, close to 40 million people. So generalizability, I think, is there. I mean, there are lessons learned from California. There's certainly unique factors in California that are independent of the survey. But in terms of representation and coverage, not just the majority, but all the folks in the periphery that need to be heard, I think we could be instructive for national policy.
And then perhaps you want to talk about the network.
And if you need help, we are here to help you. We lead the national network of state and local surveys. Dr. A.J. Scheitler is here in the room with bunny ears. She's the only one in costume. And because she represents the rest of the United States. So we lead a network where we learn and teach each other and share resources with survey leaders across the nation. So, for example, Health of Houston, there's a Colorado survey, an Iowa survey. So the behavioral risk factor survey leaders are also part of our national network. National Center for Health Statistics survey leaders are also part of a national network. And so we get together and try to share what we learn in trying to identify the needs of populations in a population representative survey.
All right, well, that's it. I want to thank our speakers and the CHIS team for working so hard, and please join us on November 30th for our next topic.